Hello everybody, my name's Cheryl Grindell. I'm a PhD student at the University of Sheffield and a physiotherapist at Sheffield Teaching Hospital. My presentation today is on a systematic review that I completed as part of my PhD, and it's titled The Use of Co-Production, Co-Design and Co-Creation to Mobilise Knowledge in the Management of Health Conditions. So first of all, a little bit about knowledge mobilisation and co-production. Knowledge mobilisation is the term used in healthcare literature to describe the active, iterative and collaborative process of generating, sharing and using evidence in all its forms. It can be quite a confusing concept and is often considered an umbrella term encompassing other forms of knowledge sharing such as translation, exchange, utilisation and dissemination. However, it can be argued that these terms actually do have different meanings, but often in the literature they are used interchangeably. We know it is important to consider all those involved in the healthcare process in order for research to be impactful. It is recognised that sharing and generating knowledge between service users and providers can help improve understanding of living and treating different health conditions. Co-approaches to knowledge production have been advocated to bridge this knowledge to practice gap. Whilst reading around the vast literature in this area in healthcare for my PhD, I noticed that there are many collaborative and participatory methods being used in healthcare research, often with lots of different approaches and many different terms being used. Co-production, co-design and co-creation were some of the most common terms. However, there appears to be a lack of consensus within the literature of what these three terms actually mean or describe, and often some of the approaches being used may lack the utilitarian and egalitarian values of what should be considered genuine co-production. So in order to try and make some sense of these two complex fields, knowledge mobilisation and co-production, and to gain a better understanding of why and how these three specific terms are being used in the knowledge mobilisation field, this systematic review was undertaken. This review aimed to answer the following questions. What is the rationale for using co-approaches to mobilise knowledge in the management of health conditions? What mechanisms of co-approaches achieve knowledge mobilisation, actual or perceived? What type of activities are used within the co-approaches to mobilise knowledge in the management of health conditions? And to what extent do co-approaches achieve knowledge mobilisation, either actual or perceived? This was a mixed studies systematic review and was based on Pluy and Hong's 7 steps of undertaking this type of review. So first of all, the review questions were developed as previously described. And then the PCOS framework was used to define eligibility for the studies to be included in this review. One of the three terms, that is co-production, co-design and co-creation, had to be explicitly used as a study's knowledge mobilisation approach in order for it to be included in this review. So if their approach for knowledge mobilisation was not explicitly called co-production, co-creation or co-design, it wasn't included in this review. A search strategy was then developed with an information specialist, but then I ran the searches independently on a number of databases, including Web of Science, Embase, Medline and CINAHL, as well as the University of York's database, the Cochrane Library and the TRIP medical database. Grey literature searches were also carried out. Once the search results were exported and duplicates were removed, the papers were then screened to identify potential studies. Papers were screened by title and then abstract initially, and then full text papers were then screened. I was assisted in this process by a second reviewer. As you can imagine, the screening process for this review was extremely difficult, and any uncertainties were discussed and agreed with reviewer 2 before the final studies were selected. Once we'd agreed upon the full text studies for inclusion within this review, the data was extracted and then quality of each of the studies was assessed using the Joanna Briggs Institute qualitative checklist. This was used as a best fit where there were no specific checklists available, for example, for study protocols and case studies. Finally, the data was then synthesised using Thomas and Harden's thematic synthesis approach. The systematic review process followed the PRISMA 2020 checklist, and as can be seen from the diagram on your screen, you can see that from over 1,000 potential articles, 24 were finally included in this review. So just a little bit about the characteristics and quality of the included studies. 24 international studies were included in this systematic review, so from the UK, Australia, Canada, Sweden and Italy. The majority were qualitative case studies, but there were also some study protocols and 3 casebooks. The health condition focus of the studies was varied and included arthritis, cancer, mental health, amongst other health conditions. Out of the 24 studies, 18 were assessed as moderate to high quality. Those that scored low tended to be those studies where the qualitative checklist was used as a best fit. Therefore, this may have been why their scores were lower. So what were the findings from this systematic review? 3 main themes were derived from the data from the included studies. These were key aspects of co-approaches for knowledge mobilisation, mechanisms of action, and outcomes of co-approaches for knowledge mobilisation. The key aspects were bringing people together as active and equal partners, valuing all forms of knowledge, using a creative approach and using innovative, iterative prototyping techniques. It was anticipated or perceived that by fulfilling these key aspects, you would then achieve the following mechanisms of action: a shared understanding, identifying and meeting needs, giving power and voice to all involved, creating a sense of ownership, and generating trust and confidence both in the process and of the produced products. These key aspects and mechanisms of action would then lead to the following outcomes: more relevant and acceptable research products, more usable research products, and implementation into practice, with an ultimate aim of improving health outcomes. You can see along the bottom of this diagram are the co-approach activities used within the different studies in this review, and these were many and varied, ranging from semi-structured interviews to more creative activities such as forum theatre and making. However, there was no particular pattern to the different types of activities used, regardless of the term chosen to describe the co-approach. That is, a variety of different activities were used for all of the 3 terms. So, for example, co-production of a research project, but another study co-designed a research project without using radically different activities. and not all of those that chose more creative activities called their approach co-design, as you might expect. So as you can see from this findings diagram, all of the included studies aim to achieve elements of the key aspects and mechanisms of action in some shape or form in order to successfully mobilise knowledge. However, these results came mainly from what the authors either aimed to do or perceived they had achieved, rather than any robust evaluation and health outcome measurement. Regardless of this lack of robust evaluation, the findings do fit with other co-production principles and frameworks. For example, the UK's National Institute for Health Research Principles for Co-Producing a Research Project and Langley et al.'s Collective Making Framework. In fact, some of the studies in this review perceived that they achieved some of the similar influences on participants' knowledge and implementation, as in Langley et al.'s framework, without using more creative activities. So what are the key take-home messages from this systematic review? We found no consensus over the description or type of activities used for the three different terms: co-production, co-design and co-creation. Despite this, all of the studies in this review wanted to achieve or intended to achieve or perceived that they had achieved the key aspects, mechanisms of action and outcomes are required to achieve successful knowledge mobilisation. Therefore, we suggest, rather than spending a lot of time considering whether your approach is co-production, co-design or co-creation, just make sure that it is co. Then use this framework or logic model from the results of this systematic review to help you choose the right activities or adapt the activities that you want to use to ensure that your approach is truly co, and to help you fulfill the key aspects and mechanisms of action required to help you achieve the outputs for successful knowledge mobilisation. So thank you everyone for listening, and if you have any questions, please do not hesitate to get in touch. As I recorded this presentation, the full systematic review paper had been accepted for publication by BMC Health Services Research Journal. So hopefully by the time you are listening to this presentation, it will be available open access in this journal for you to read. Thanks again.